So I'm happy to be here to talk a little bit about our Help Prevent Diabetes study. It's a implementation study, a translation study, not really a dissemination study at the time that we started, but we're in a dissemination mode now, and we can talk about that during the discussion time. I don't really get into that probably in the first 10 minutes. So one of the themes you heard, start with a proven intervention that's efficacious. And so that's where we started. So let's talk about diabetes prevention, and then Spiro may not have to do that. There's a whole lot of people with diabetes, and there's even more people with prediabetes. Prediabetes is the kind of condition that increases the risk for diabetes. About 10% of people with prediabetes convert to diabetes every year. And there's a whole lot of people with prediabetes, 79 million in the United States and even more globally. Several big efficacy studies show that if you do lifestyle interventions with people with prediabetes, you can reduce the risk of converting to diabetes. Okay, but those studies were done with highly trained interventionists working one-on-one with individuals in expert settings, highly selected participants. 60% reduction in risk. But can we do that? We don't have enough trained behavioral interventionists to interact with 79 million people in the United States, much less hundreds and hundreds of millions, perhaps over 1 billion. Okay, hundreds of millions at least globally. So, what do? You try to translate that kind of intervention into something you can implement in the community. And that's where we were when we started this study now probably 6-7 years ago. So we wanted to translate this highly efficacious intervention to something that could be done in the community in a group setting with lay health professionals, lay health counselors, really, is what we started calling them, but now they're called community health workers. And so our setting was to get participants who are overweight or obese who have prediabetes and intervene in a group basis instead of one-on-one through an existing community resource, a diabetes care center, that would engage community health workers, lay people, in delivering the intervention. We had stakeholders involved in the community. The Diabetes Care Center, as part of their certification by the ADA, has to have a community advisory board. So we had a community board already in place that we could work with and say, we would like to expand the mission of a Diabetes Care Center to include diabetes prevention. Are you in? Are you interested? Oh, they thought it was great. Okay, so that was wonderful. We were advantaged by that. Okay, so what did we do in terms of partnerships? Well, we had to have a partnership with the Diabetes Care Center. That was the first thing. We worked with their certified diabetes educators to develop a partnership with them because they were going to be the ones who were going to host the intervention, as you'll hear more about. They were going to select the community health workers and train them, as you'll hear more about, and support them in their delivery of the intervention. So it was critical to have a good relationship with the Diabetes Care Center and their diabetes educators. Next, we had to have a partnership with the community health workers, and that partnership was at an arm's length because it was through the diabetes educators, not directly from the research team. And then we also developed partnerships with community organizations that were going to participate in and support the intervention. Some examples here are things like the YMCA. We had people come in from the YMCA and talk with our participants about the importance of stretching before going out to do exercise so there wouldn't be as many injuries. Lowe's Foods is a major food chain in North Carolina where this occurred, and we had a dietitian come in from Lowe's Food and talk about how to shop and get healthy, affordable foods, and also took them on a field trip. And Fleet Feet was a shoe company that came in and talked about the importance of wearing good shoes that support your arches when you go out walking, because many of our participants were women and lower income women whose variety of shoes for walking might have been limited, right? So very important. They also provided discount coupons for buying walking shoes at Fleet Feet. And then, of course, we had to have partnership with the participants. That occurred at several arm's lengths because that occurred between the participant and the community health worker. So, and then the community health workers were partners with the diabetes educators who were partners with the research team. So several arm's lengths between the participants. So we were focused from the beginning on effective dissemination, and that's why we tried to keep the research team as far away as possible from the participants. The last thing we wanted was for me to see a participant. That would have been absolutely awful. And I can tell you it never happened, except when someone came up to me in the community who I knew and said, I got this letter from you in it. Do you think I'm fat? Because we did some community mailings, and they would say, I enrolled. And I would say, that's great. That's great. So we trained the trainers who trained the trainers. That's what not just one arm's length away, but at least two. We developed enduring materials that the community health workers could use so that they didn't have to be content experts. We monitored costs, including participant costs, because if you want to disseminate something like this, somebody's going to ask, what does it cost? We had a great economic analysis. And we had complete separation of research assessments from intervention visits. We had research assessments happen in our GCRC, what predated the CTSA, and done by separate staff who had no idea whether these were intervention participants or comparison participants. What else did we do to try to translate from the high-tech efficacy study to the simpler study? We simplified eligibility criteria. We didn't require an oral glucose tolerance test. Just a simple fasting glucose had very few exclusions. We did community-based recruitment, mailings, a phone bank, clinic referrals. We based it in the community-based ADA Certified Diabetes Care Center with our certified diabetes educators. We recruited community health workers from their existing patient population of patients with diabetes who'd gone through diabetes education and made lifestyle change. People who were readily at hand. So they didn't have to go looking for community health workers very far away from their day-to-day activities. And the concept, which will come up again on the next slide, is that participants who went through the program could become the next group of potential community health workers. So when you ask me what our framework was, it was the Amway model. Yeah. Who remembers Amway? Not very many people. Okay, so what else could I call it? Could I call it the Tupperware model? Does that help, or is that even further away? You know, somebody comes in and does a Tupperware party in your house, and then you're expected to become a Tupperware salesperson. Okay. So why did we take this approach? Well, the first thing we said, the research team can't possibly interact with all the participants with prediabetes. We can't even train all the community health workers that are needed. But maybe, just maybe, we could set up a training center where we could bring certified diabetes educators in and train them in delivering diabetes prevention in their diabetes care centers. Maybe we could do that. And so that was the model that we used. Why did we think this might work? There are over 3,000, last time I looked it was like 3,500 ADA certified diabetes education centers in the country. Think about that dissemination potential if we could get all of them delivering diabetes prevention. Okay, so how did we develop the intervention? We did the typical stuff, focus groups. We tested our material on our CHWs. They were patients with diabetes who'd gone through diabetes education, and we ran a group with them to pre-test things. We developed enduring materials, and we developed process monitoring tools, including web-based monitoring tools, to help support the community health workers. Did it work? Yeah. Body weight went down. This is the intervention group, lifestyle, weight loss, as opposed to usual care. Body weight went down. That was great. Blood glucose went down. Stage separated. That was great. So it worked. And it actually saved money, although that's not what we're here. It saved money for everybody except the participants, which is something we'll have to think about. Maybe in certain models with high deductible insurance programs, it might even save money for the participants, but it certainly saved money for health system perspective and from a societal perspective. So then we have to figure out how to make that pay off for the participants who spent more money on shoes, spent more money on food, turned out, but spent less money on doctor's visits and so forth. And society spent less money. So what are the lessons we learned? Focus on proven efficacy. You heard that already. Think about dissemination first and second and third, fourth, fifth. When you're monitoring your implementation, always be thinking about dissemination down the road, because it doesn't really matter if it works in your setting if you can't do it other places. And be cautious. This was so hard. We would kind of think we were learning something in the middle of doing this intervention, and somebody said, well, why don't we do X next? It was like, well, can X be done in 3,000 ADA certified diabetes education centers around the country? And if the answer is no, don't do X. For us, that was our answer. Okay, so tempting as you're going along to think you're learning something really cool and you can just tweak your intervention could ruin your ability to disseminate down the road. So be very, very careful about improvements and adjustments. You know, people will say, you've got to be flexible. That's true. But be flexible in a way that your ultimate dissemination channel can also be flexible. And then there's references. They said provide references, and these are going to be available on the web, right? So they'll be there, and it includes economic analysis. So I think I'm done.